Hey guys, welcome to my channel. My name is Dr. Rola Rabah. I am an oral maxillofacial surgery resident. I am doing my general surgery engineer, and this is my last night shift of 2020. I cannot believe it. I have done what seems like a lot of night shifts, and so I have tons of those vlogs on my channel. Don't forget to go watch them. Today I'll take you on my journey during this night shift. Unfortunately, COVID-19 cases are surging in a lot of different states, and so things are looking a little bit different in the hospital. Getting prepared for that before I move on to my next rotation. But I will show you guys what the night looks like. Don't forget to subscribe to my channel, check out my other videos, and follow me on Instagram at 15 Blades. Okay, so I just got sign out from the resident that was on over the day, and basically the resident will put together a handoff, which ends up being your list. I write down any to-dos overnight, and then basically my flow of the day after sign out is I go see all of my patients. I do my PM rounds. I take notes of things that need to happen, and then I go back to the workroom after I see everybody, sit down, get anything done that needs to be done on the computer, follow up any x-rays, look at any labs that were ordered, any studies, update the handoffs, and then once I'm done with that, I will sit down and try to have dinner. Afterwards, then I will go back and check on any patients that I need to see for the second time. That all depends on what's going on with the patients, of course. That doesn't always happen. And then once I'm done with all of that, I'll try to maybe get a nap in. And then, of course, during the whole night, you're answering pages. A lot of times you'll get pages about pain management. Sometimes patients need certain medications that you need to order. Sometimes they'll have certain physical exam findings that the nurses might find, like new abdominal pain or distension that I have to go evaluate. So throughout the night you're answering pages. I get a little cat nap in here or there. It all depends on the night and how big the list is, but generally speaking I'm covering multiple services. So tonight I'm doing vascular surgery, general surgery, and thoracic surgery. So we'll see where the night takes us, but I've got my pager, got my list, and I'm gonna go see my patients. So it's about 6:30 p.m. I just finished sign out. I'm going to go and see all of my patients on PM rounds because COVID numbers unfortunately are rising. We are being extra vigilant about making sure that we are not spreading COVID to our patients and we're not getting it ourselves. So we have to really be protected. Even with patients who do not have COVID, we are wearing a mask, a face shield, or eye protection, and then if we're touching patients, we put gloves on. And so I have to say that it does get overwhelming to have this much PPE on all day long, but it's definitely better than when you are in the COVID wards and you have to put on the N95 as well, and the gowns and all of that. And of course we're very fortunate because we've always had PPE, and some hospitals are struggling to get PPE, so I really can't complain. But after a long day, you feel like you're like not oxygenating as well because of all of the PPE that you have on. But you have to stay protected and vigilant, and the last thing that I ever want to do is get COVID and then spread it around to my patients, and so we all are extra careful. Okay, so the first thing that I do before I sign in is I actually wipe down all of the surfaces with bleach. It's something that I picked up during the pandemic, and I do it every single day. One of the things about night shift is that people will bring snacks. So someone brought Dunkin' Donut coffee. So it's about 8 p.m. I'm going to heat up my dinner. The thing about night shift, we really don't have anything open, and when it gets late around the hospital, there's not that much delivery too, so I try to bring food from home. Even sit down to eat, you guys, because I got a page already. Let's go see what's going on. All right, so I just got a page that my patient was vomiting, and so I went and evaluated them because it's super, super important to do a physical exam on a patient that's vomiting. That's one of the things that I have learned on general surgery, and a lot of you guys have asked me to share some tidbits and helpful hints, and so this is definitely one of the biggest one. Whenever any of your patients have any sort of new exam findings, so they're nauseous, they're vomiting, they suddenly have abdominal pain, definitely go evaluate them because you never know what's going on with them. And one of the most common things that can happen with someone who just had abdominal surgery or has a history of abdominal surgery is something called an ileus or small bowel obstruction. They're kind of two different processes, but definitely something that you should go evaluate. And a lot of times the initial treatment is similar. So this is just something that I've learned on general surgery, and I can kind of talk about it a little bit in very brief detail. Of course, I'm not an expert, but it's something that as an intern you'll have to deal with a lot. And so if someone is vomiting all of a sudden, and especially if they've had abdominal surgery, it's very common for them to have something called an ileus. And an ileus is basically hypofunction of their bowels. And so the bowels are very, very sensitive. As soon as we open them up for an appendectomy or a cholecystectomy, they're very sensitive, and they might have a decline in function. And so what happens is, because things, that normally go through your mouth into the esophagus, into the stomach, small bowel, large bowel, and then out through the rectum, that normal pathway is no longer working because your bowels, your small bowels, are hypofunctioning, so they're not moving food like they normally do. So what happens is things back up, and of course they back up from your small bowel into your stomach, and then what doesn't go down has to come up, and patients will start vomiting. The way that you treat that is you stop the patients from eating anything, because of course there's nowhere for it to go. So you stop them from eating anything, and then the next thing you have to do is decompress the stomach. So the way to decompress the stomach is to put something called a nasogastric tube down the nose or the mouth sometimes. And that would be an oropharyngeal tube. And the reason why you want to put a NG tube in the nose is because you want to get all that fluid out of the stomach. That will actually make patients feel much, 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 much better. And once you decompress their stomach, you give their bowels some time for them to return to function. And once they start passing flatus, and once they start having bowel movements, then you can clamp the NG tube, remove it, and then they can start eating again. So basically it just gives the bowels a chance to recover. And so that's an ileus. A small bowel obstruction is a little bit more complicated. Usually happens in someone who's had abdominal surgery in the past. They have something like adhesion. Sometimes it can happen if they have some sort of hernia that's getting incarcerated. And a small bowel obstruction is a little bit different. You do start initially with the same thing. You make them NPO, so they can't have anything to eat or drink. You put a nasogastric tube in order to decompress their stomach, and then you can do lots of different things. One of the most popular things that you can do is a gastrographin protocol, where you put contrast that actually allows the bowels to also move as well, and that will give you imaging that's really helpful to see whether or not they have an obstruction. If there's a transition point, that's usually the best study for that is a CT scan, but I won't get into the nitty-gritty details. It's just kind of an overview of a small bowel obstruction. A lot of times the gastrographin protocol and medical treatment will actually get the bowels, the obstruction will open up, and you'll get return of bowel function, and you do the same thing. You'll clamp the NG tube, and then if they pass it, remove it and advance them slowly. If that doesn't work and they still have that obstruction for whatever reason, that can actually be a medical emergency if they get incarcerated bowel. You don't want bowel dying, that's always bad, and so that ends up being an emergent OR. And so a lot of times they'll go to the OR, and they'll have to actually go in there and remove and relieve the obstruction. And so that's ileus versus small bowel obstruction. So basically the lesson to learn here is really physical exam is so important. If your patient is vomiting, don't just throw Zofran or Reglan or Phenagrin on them. You should definitely always go evaluate the patient, because it's so important to know what's going on underneath all of it. And so that's what I did with my patient, and that's one thing that I've learned on dental surgery. Hopefully that's helpful. Okay, so it's about 11 p.m. and I want to take a little bit of a nap because it's quiet, but I'm also really craving a snack. So there's not much that's open, not very many options this late in the night, but we get this key to this refrigerator that magically gets stocked somehow, and I am going to go and see what's inside today. Sometimes it's really good and sometimes it's like nothing's in there. So it'll be just my luck. Let's go see. So this is that mysterious fridge, you guys. Doesn't look like there's much there. Let's see what we've got. Here's some salads. They've got peanut butter and jelly, some ham and cheese, which I don't really eat, some water, yogurt, cottage cheese, hard-boiled eggs, and a couple of pieces of fruit, so not really much. Should I get a garden salad or a peanut butter and jelly? I think I'll go for the peanut butter and jelly. Not bad. Could be worse. When it's just you and a robot in the hospital at 1 a.m. Come on, dude, let's go. Oh, I think it wants me to get out of the way. Bye. So one of my patients is short of breath and I ordered a chest x-ray, and now I have to wait for the x-ray techs to come up to the floor and take the chest x-ray, but I'm getting so sleepy because it's so late into the night, and so I am gonna go on a very long walk in the hospital, and I try to just take the stairs, get a little bit of exercise, and that's one of my tricks to staying up when I am losing energy. So I'm gonna show you guys the on-call room. Basically, it's nothing fancy. It's just a computer, which is very important for me to hop on and see if I need to do any patient orders. And then there's a bed. They actually give us towels if we want to take a shower, and blankets, sheets, and pillows and covers. I bring my own warm fuzzy blanket because hospital on-call rooms tend to be really cold. So that's one of my biggest advice, and I actually have a video about my tips and tricks to managing night shift, and I give you guys some of my secrets, including but not limited to bringing your own blanket from home. All right, so it's about 2 a.m. Things have quieted down. Everything that I need to follow up on, I've already followed up on, so I am going to get into bed really quickly and try to take a little cat nap. It's time to wake up. I actually got 2.5 hours of sleep, which is amazing on night shift. It's winter time, and because of COVID and the surge that's happening, a lot of people are not coming in for elective surgery, and people just avoiding the hospital. So the service has been slower than usual, and I actually got to sleep a little bit, which is great because now when I go home I won't sleep as much, but I have to get up now, go see a couple of patients. It's about 4 a.m. I'm going to prepare the handoff because all the residents come in at 5:30 and I have to be prepared to sign out all of the patients, and there's a couple of patients I want to see before the residents get here. So all right, you guys, so it's 6 a.m. and I'm finally going to go grab my stuff and head home. All of the residents get in at 5:30 in the morning. I sign out to them, and then I go home, and this is my post-call day. So I'm gonna go home and sleep, and then I'll have the rest of the day to kind of recover and switch over to day shift, because for the remainder of the week, I am going to be back on day shift, and this is actually my last week of general surgery before I go off to anesthesia for a couple of months, which is part of my OMFS year. Officially done with my last night shift of 2020. I am heading home to get some sleep. It really wasn't a very bad night, and so made for a great last night shift. Don't forget to please subscribe to my channel, like this video, comment below. If you want to see more posts like this on the daily, follow me on Instagram at 15 Blades. Thank you so much for tuning in, you guys. I'll see you next time. Bye.